Good afternoon, my name is Ben White, fourth semester nursing student, and today we're going to be doing a teaching project on AV heart blocks. Our crowd is going to be medical professionals, so they already have a baseline understanding about AV heart blocks. We're just going to kind of go in depth a little bit in the identification and the treatment of AV heart blocks. First thing we're going to talk about is the actual knowing the conduction path of the heart rate, because in order to distinguish a heart block, we have to know the normal conduction pathway. We're going to start with the SA node, which is located in the top right chamber of the, or top right part of the right atrium. It fires, sends its impulses through the internodal pathways. It's going to hit the bundle of His, or the AB node. AB node slows down, then sends it down to the bundle. The bundle branches it through the Purkinje fibers into each ventricle and causes the fire. Now, where most of the time when we start having problems with AV blocks, it's going to start taking place right there around the AV node or just below the AV node. And when we start having when we start having AV blocks below the AV node, that's when we start to get in what we call high degree heart blocks, second degree type 2 and third degree heart blocks. First one we're going to talk about today is going to be a first degree heart block. And the number one way to distinguish a heart block, no matter what it is, whether it be first degree heart block, second degree type 1, second degree type 2, or third degree complete heart block, is our PR interval. Now, the PR interval is actually the amount of time that the electrical impulse travels from the atrial or the SA node into the AV junction. And the AV junction is what holds on to the electrical impulse. It's giving the ventricles time to fill, and then we fire. Okay. What makes a first degree heart block, I'm going to show you right here on the monitor, is you have a prolonged but constant PR interval. So if you look at your PR interval, and it's kind of hard to show you on the monitor without printing it out, but if you had your little diagram there, or your little graph paper on there, your lead paper, you would see it. Your PR interval is greater than 0.20 seconds, and if it is greater than 0.20 seconds and remains constant throughout, then you have a first degree heart block. Now, throughout literature and throughout the changes, we've come to figure out that a first degree heart block falls under the category of a heart block, but it's not necessarily a block. It's technically a delay. It used to be it was considered a heart block, and as the Academy of Cardiologists and all that looked into it, they realized that it's not actually a heart block. They don't want to change it all, so it still falls under the category of heart block. All it really is a delay in the electrical impulse from the SA node to the AV node. The treatment for a first degree heart block is going to be completely symptomatic treatment. You're not treating the actual first degree heart block itself. You're going to be treating any symptoms associated. 9 times out of 10, this is going to be a monitor patient. You're just going to monitor them. You're not going to wake a doctor up in the middle of the morning for a first degree heart block. You're not going to call a cardiologist at 2 o'clock in the morning for a first degree heart block. If your patient, however, is symptomatic, usually more than likely it's going to be caused from something else, and you're going to be treating those underlying reasons. Now, the next thing we're going to talk about, and now we're going to start actually getting into some heart blocks that are really considered a heart block. The next one, and I'm going to slow the rate down for you, and we call this the second degree type 1, or a Mobix 1. And what this is, if you look at your PR interval, your PR interval gets wider, 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 and you drop a QRS. There's where your block comes in, because in order for it to technically be called a block, what has to take place? You have to have a block of electrical impulse. Okay? So when we drop that QRS beat here, there's where our block comes in. Quickest way to distinguish, and people are really scared about heart blocks. They say heart blocks, I don't even want to have anything to do with them. If you ask me, to be honest with you, heart blocks are probably one of the easiest rhythms to interpret, because the only way that you can justify a heart block and interpreting a heart block is through your PR interval. We know that a first degree heart block, like we just talked about, we have a constant PR interval greater than 0.20, okay, or 0.12. With a second degree type 1, like you see here, what's happening is your PR interval is widening, and then it drops off a beat. Our block kicks in. And sometimes you'll hear some of your cardiologists say it's a second degree type 1 with a 2 to 1 conduction rate. All that means is the atria are firing 2 times for every ventricle fire. Okay, that means there's 2 electrical impulses coming through the atrium and getting through to the ventricles, and then we lose a beat. Okay, so another name for this is called the Winky Bach. I like to call it a Winky Bach when I talk about second degree type 1s, is because it's easier to describe. Because remember, the number one way to determine a second degree type 1 is what happens to the PR intervals. They widen, 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 drop a beat. Okay, I like to call second degree type 1s the walking Winky Box. If you watch that PR interval, it walks out, it walks out, walks out, it drops. Starts all back over, walks out, walks out, walks out, drops. And you notice how I walked out, walked out, walked out, drop? That's 3 to 1. If it was to walk out 4 times, it'd be 4 to 1. Okay? And you don't really need to get wrapped up in your conduction fires on that, because a second degree type 1 is a second degree type 1, no matter what the conduction rate is. The treatment for second degree type 1 is usually, again, is a kind of a monitor patient unless we're showing signs and symptoms of hypoperfusion secondary to more than likely a bradycardic reason. And we're just going to follow our normal bradycardic algorithm on this. These patients are going to get some atropine IVP at a 0.5 up to a 3 milligram max dose, but you're going to give it in 0.5 milligram increments. Now here in a second, we're going to talk about second degree type 2s and third degree heart blocks. And you're going to see that atropine is going to be pushed to the side. And the reason is, atropine, the easiest way to remember this, atropine works in the SA node. If we have an AV block, what is not correlating with each other? The AV node, the SA node and the AV, okay? Atropine works in the SA. Atropine works in the SA. So if we've got something that got a dissociation, then atropine's not going to work, okay? So then we go to a second degree type 2. Now, second degree type 2 is actually easier to define or identify than a second degree type 1. Because look what's taking place on our monitor. What's our PR interval doing now? Our PR interval is staying what? Fixed. Staying fixed, but what do we see every once in a while? A drop beat, okay? Anytime we got a drop beat, that lets us know in our head that we've got what taking place? Some form of a block in the electrical activity, okay? So we know with a first degree type 1, or first degree, I'm sorry, not type 1, first degree, our PR interval is wide and constant, second degree type 1. Our PR intervals get wider, 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 drop. Second degree type 2, we have a fixed PR interval that drops an occasional beat, okay? Here's where we start pushing atropine to the side and treating these patients, and we go straight to transcutaneous pacing. And every monitor is set up different, but every monitor functions the same way when it comes to transcutaneous pacing. And we're not going to get into actual transcutaneous pacing on it. This is just strictly identification and treatment of this rhythm. And the last one, a third degree, or AKA complete heart block. Whenever you hear the terms complete heart block, you should automatically start registering in your mind, I have complete block from AV and SA, or let me say, I said it backwards, SA and AV, okay? So in medical world, we also call that a complete disassociation, an atrial and ventricular disassociation. That means the atria are doing their own thing and the ventricles are doing their own thing, and there's no correlation with each other. Your atria are firing at normal SA rates, 60 to 100, and your ventricles are going to fire at their normal 20 to 40 beats per minute. All right, usually with your third degree heart blocks, you can see your QRSs do widen out a little bit, but notice the main thing about it is there a QRS for every P wave on that monitor? There's not. Remember, it's a complete disassociation. SA node, AV node, and down have no correlation with each other. Okay? So, which one is a constant PR interval but drops an occasional beat? Second degree type 2. Which one is a constant widened PR interval? First degree. Okay. Which one is a complete disassociation between atria and ventricle? Third degree. All right. All this goes, the PowerPoints that I give you, put you in front of you, every bit of that goes along with this. What I've done was kind of a cut down version of it. but it kind of goes a little bit more into detail there. Also, I have a quiz that covers the same material that we just talked about. I urge you to take it. You can get back with me at my number, or you can contact me via email at gwhite2@meridiancc.edu, and I will give you the answers to it. Do you have any questions? Thank you for your time.